Hi guys, give me a thumbs up if I'm live and audible to all of you. So we're continuing our Farre series. We have done the basics of respiratory medicine. We have done some important questions from the cardiology, and we are continuing to cardiology too. So there are four more questions that we will discuss today, and then I will pass the baton to the next faculty who will continue with these topics for a couple of days, and then I'll be back again taking up the other systems in medicine. Okay, so we'll start with cardiology 2. So what are we going to cover today? We will talk about cardiac tamponade, which is usually a 5-mark question. We'll talk about atrial fibrillation, which can be a 5-mark or a 10 marks question. We will talk about ventricular tachycardia, which is usually a 5-mark question, mostly focused on management of ventricular tachycardia. And then PSBT, again, management is what it is usually asked for 5 marks. Okay, so we'll start with the first question, that is cardiac tamponade. Most university questions are going to read like this. Discuss briefly the causes, features, and management of cardiac tamponade. Right? So if it is a 5-mark question, how will they distribute the marks? So for the causes, they will generally give 1 mark because there are not a long list of causes that you should be writing about. Clinical features, you can give around 3 marks, and for the management of cardiac tamponade, 1 mark. That is how the distribution of answers. Okay. As I've already told you in the Farre one, whenever you are asked to write a 5, 10, or a 20 marks question, even if they do not ask the definition, it is always wiser to open with the definition. Of course, don't waste 3 or 4 minutes writing the definition. Try to write succinctly in 1 or 2 sentences. Okay, so what is cardiac tamponade? We will define it as a life-threatening condition in which fluid accumulates in the pericardial sac. Now, if fluid accumulates in the pericardial sac, that is equal to pericardial effusion. That is not cardiac tamponade, right? I have to make it clear to the examiner that I know what is cardiac tamponade and I'm not restricting to just the fluid accumulation in the pericardium. So, what is cardiac tamponade? This accumulation of fluid in the pericardium can lead to increased intrapericardial pressure. Increased intrapericardial pressure should reach a point which impairs the ventricular filling. So if less amount of blood gets filled into the ventricle, then less amount of blood will get ejected out from the ventricle, resulting in decreased cardiac output. So as an examiner, I would be expecting these 3 terms. One, you should mention that there is pericardial effusion or fluid, which has resulted in increased intrapericardial pressure, which is resulting in impaired ventricular filling and the cardiac output. Now, when do you say intrapericardial pressure is significantly increased? Remember, you can mention this in the question. In cardiac tamponade, intrapericardial pressure is usually more than intrapericardial pressure is usually more than 15 millimeters of mercury. It's more than 15 millimeters of mercury. Okay. If you want to represent all these points on a pictorial or a graphical representation, we can do that. We can have a nice sketch of ventricles. Right, let us see, this is heart, interventricular septum, left ventricular free wall, right ventricular free wall. Okay, around that we have the pericardial sac, and in that sac we have accumulation of fluid, and this accumulation of fluid results in pressure more than 15 millimeters of mercury exerted all over the ventricles. Left ventricle being slightly more stiffer, it resists the collapse. But on the other hand, right ventricle is not as stiff as the left ventricle, so it gets collapsed usually under the influence of this pressure, right? So this is my left ventricle, this is right ventricle. You can fill the fluid into this pericardial sac to say that it is the pericardial tamponade that we are talking about. Just accumulation of the fluid is not tamponade. When the pressure is more than 15 millimeters of mercury, it causes collapse or compression of the right ventricle, results in reduced filling of blood into the right ventricle. If less amount of blood comes, less amount of blood goes out, so thus the cardiac output is reduced. Okay, so you can even label these findings that in the cardiac tamponade, the right ventricle is collapsed right ventricle, then there is massive pericardial effusion, and I have already mentioned the pressure inside the image. So that kind of completes our pictorial representation of what is the cardiac tamponade. The key point here is there should be hemodynamic compromise. Means if filling is reduced, less amount of blood goes from right ventricle to the lungs, less amount of blood comes from lungs to the left side of the heart, less amount of blood get ejected from the left side of the heart. So cardiac output will be reduced, and whenever cardiac output reduces, BP tends to drop. Okay. Now what can cause? Now for me to accumulate so much of fluid inside the pericardial cavity that will result in collapse of the right ventricle is not easy. Means if I have, let us say, nephrotic syndrome, or if I have heart failure, the edema will not be so sufficient for us to compress or collapse the right ventricle. What can make it compress or collapse? Mostly bleeding into the pericardial cavity. So the first cause you should actually mention is the hemopericardium. Hemopericardium, bleeding into the pericardial cavity. What can be the cause for hemopericardium? What can make us bleed into the pericardium? Right. It is most commonly caused by trauma. The trauma can be road traffic accidents. You might have heard a lot of people, they sustain steering injuries to the ribs fracture, go penetrate into the pericardial cavity and then cause rupture of some blood vessels, and they can bleed massively, right? It can also be iatrogenic. So when we do some cardiac surgeries or angioplasties, we can injure the blood vessels, and we can make the patient bleed into the pericardial cavity, right? Apart from that, what other conditions can lead to mixed edema? Because of long-standing hypothyroidism, there can be mixed edema, which can also cause cardiac tamponade. In the books, you will get long list of causes, but these are the causes that examiners are expecting. You must mention road traffic accident, iatrogenic cause, and mixed edema. Okay, so these are the causes for cardiac tamponade. Now, what clinical features a patient with cardiac tamponade will present with? Okay, now to understand clinical features, we will take just 2 minutes to understand the pathophysiology. So what happens in the cardiac tamponade? Pathophysiology of cardiac tamponade. So first thing that happens in the cardiac tamponade is there is development of massive, means large amount of pericardial effusion. Or bleeding into the pericardium, that is hemopericardium. This results in increase in intrapericardial pressure greater than 15 millimeters of mercury. That will result in collapse of right ventricle. Now, is it easy for me to push the blood into a small chamber from the right atrium? Here I have right atrium. I have to push this blood from right atrium to right ventricle. Is it going to be easy? No. Remember, we have a physics law called as Boyle's law, which says pressure is inversely proportionate to volume. So now what has happened to the volume of the right ventricle? By collapsing, its volume is reduced. That means pressure inside the right ventricle has increased. So now for me to fill the blood from right atrium to right ventricle, I have to generate much higher pressure in the right atrium, because only when right atrial pressure is higher than right ventricle, the blood will go into right ventricle. So it becomes increasingly difficult for me to fill the blood into the right ventricle. And we know that the blood from right ventricle is supposed to go to lungs, and from the lungs it comes to the left side of the heart. So if I have reduced filling in the right, less amount will go to lung, less amount will come to the left side of the heart. So left-sided filling will also get reduced, right? So collapse of the right ventricle result in decreased right ventricular filling. Decreased right ventricular filling results in decreased right ventricular output. Less amount of blood is coming out from right side of the heart. That results in decreased left ventricular filling, because left ventricle blood only comes from lungs, right? Left ventricle doesn't receive any extra blood supply from any other locations. Whatever blood goes to the lungs comes to the left side of the heart. So if there is decreased left ventricular filling, it will also result in decreased left ventricular output. That is our cardiac output. And when cardiac output decreases, there can be hypotension. hypotension. So one of the clinical feature we can expect is hypotension. So these patients will present with hypotension. BP will be generally low. Okay. Now, when I try to fill the blood into this collapsed right ventricle, right, this right ventricle is collapsed, I try to push hard into this right ventricle from the right atrium. What will happen to right atrial pressure? The right atrial pressure will increase. And we know that right atrial pressure is directly proportionate to, or it is correlated with the jugular venous pressure. So if right atrial pressure is going high, even the jugular venous pressure will increase. So I can have rise in JVP. So the second finding I can get in these patients is increased jugular venous pressure. Hi Vishal and hello doctor. Increased JVP. Now within the JVP, we should also mention that there are different waveforms of JVP, right? A wave, then C wave, X descent, Y descent, V wave. What changes do I get in the waveform? So remember here in the cardiac tamponade, I'm struggling to push the blood from the right atrium to right ventricle. So right atrium generates more pressure. So when it is contracting, pressure in the right atrium is increasing. And which wave on the JVP represents the atrial contraction? A wave. So if the pressure of right atrial contraction is higher, A wave will become prominent. So in the JVP, so normal JVP looks like this. A wave, then X descent in between a C wave, and then I will have a V wave and then a Y descent. This is a normal JVP. You can sketch this. This first upstroke is A wave, downstroke is X and X dash descent. A small upstroke is C wave. This is V wave and this is Y descent. This is normal. What happens in cardiac tamponade? So in the cardiac tamponade, this A wave, because of increased right atrial pressure, becomes taller. So now the A wave has become taller because atria has to contract more forcefully to push the blood into the right ventricle. So A wave has become tall. And because of this tall A wave, this X descent that we had, now it appears to be more steep because it has reached much height. So the downfall appears to be steep. So you can label this saying that in the cardiac tamponade, we can have tall A wave, then we can have steep X descent. From this, generally we will have a V wave, and then we are expected to have a Y descent. Now I want to tell you one important point. What this Y descent in the cardiac cycle represents. So when we transfer blood from right atrium to right ventricle, that is ventricular filling in the diastole, it happens in three phases. The first is isovolumetric relaxation, where ventricle only relaxes, no filling. Then we fill in two phases. First, passive filling, where just because of the pressure gradient, blood moves from atria to ventricle. After that, the atria contract to push the remaining blood. We call it as active filling. A wave is actually active filling, where atria is contracting to push. Right? The Y descent is because of the passive filling, where because of the pressure gradient, blood is moving. But in cardiac tamponade, what is happening? Your right ventricle is completely collapsed. Right? Can I passively fill blood into it? In a small collapsed chamber, can blood easily enter? No, I have to only actively push into it. Otherwise, passively it cannot go into it. So there is no passive filling happening in a patient with cardiac tamponade. So because of that, Y descent will be absent. So soon after V wave, it will progress to a tall A wave. Again. So there was supposed to be a Y descent, and you can label it for the exam that there is absent Y descent in cardiac tamponade. And why is it absent? Because there is no passive filling happening in cardiac tamponade. For passive filling to happen, right atrial pressure should be higher than the right ventricle. But here right ventricle is completely collapsed, and by collapsing, its pressure is high by Boyle's law. Collapse means volume decrease, pressure increase. So passive filling is not possible in the cardiac tamponade patients. Okay. Then the third thing. Now look at this. I just learned why there is hypotension, because right ventricular output is reduced. So जब blood left को आएगा वो भी कम होगा. So left ventricular cardiac output is less. So BP is going to be less. Now, second thing I learned is that JVP, why is it raised? Because right atrium has to put more force to push the blood, right atrial pressure increases, and thus JVP increases. Now, the third thing, if I keep my stethoscope here and try to auscultate, what will happen to the cardiac sound, heart sounds, S1, S2? Is fluid a good conductor of sound? Of course not, right? We have many times taken a dive in the swimming pool or the wells or rivers for swimming or taking bath, and whatever we scream inside the water, can we hear it clearly, loud and clear? No, because fluid is not a good conductor of sound. So whatever sounds that are produced by closure of valves, they will be significantly hindered or impaired when it passes through the fluid. So it sounds like, it feels like the sound is heard from a very distant location. So we will call it as muffled heart sounds. So the third thing we will get is muffled heart sounds. Muffled heart sounds. And these three things put together collectively, what do we call it as? These three things collectively, it is called as Beck's triad. It is called as Beck's triad. Beck's triad is the classical feature of the cardiac tamponade. So once you have written this, the clinical features wise, examiner is more than convinced. If you want, you can put a triangle, and in the triangle, one side you can write hypotension, other side raised JVP, and another side you can write muffled hearts. Okay. So now we have also understood the pathophysiology behind this. Now coming to the diagnosis. How do we make a diagnosis of cardiac tamponade? The investigation of choice for diagnosis of cardiac tamponade is echocardiography, or you can also consider the right heart catheterization as the investigation of choice for the cardiac tamponade. Echo is also fairly good, or the right heart catheterization. Okay. But for most cardiac patients, wherever investigation starts, it starts with the ECG. So what findings I can get on the ECG, or what should I write in the exam? You should be writing two findings and try to make a simple sketch of it. First thing, fluid is not a good conductor of sound, and also it's not a great conductor of electricity compared to other tissues. So when heart generates electrical impulses, right? Now what is ECG? Electrical impulses generated by SA node or AV node, which is traveling through the heart, is what we are recording on the surface through the electrodes. But fluid will interfere a little bit, so the voltage reaching the surface electrodes will come down. So जो QRS complex का voltage या height है, the height of the QRS complex, it will become small. So that is the first finding. You will have low QRS voltage. Low QRS voltage. If you want, you can write a small sketch like this of the ECG showing that the QRS voltage is decreased. So you can even label it for the examiner to take a quick look that you're talking about low QRS voltage. The second thing that will happen is this heart, which the right ventricle is collapsed, when I push the blood into it, it will make that collapsed right ventricle open, right? And this opening of this collapsed right ventricle makes the heart move like a pendulum. It will be pushed forward when blood gushes into it forcefully, and then when it gets ejected, it will move backward. So it starts moving like a pendulum inside this cavity. So when the heart starts moving like a pendulum inside the cardiac cavity, the heart is sometimes coming closer to the electrode placed on the chest for the ECG. So when it comes closer, the voltage will be high. But when it moves away, the voltage will become less. So alternatively, I will have a high voltage complex and the low voltage complex. So we will call that ECG finding as electrical alternance. So the second finding I can get is electrical alternance. Alternance. You can make a simple sketch showing that the voltage, QRS voltage, is alternatively small and large. Alternatively, it is small and large. This is what we call as electrical alternance. So these are the two ECG findings. Okay. Now in echocardiography, what findings we can get? What findings we can get? So first finding we can see on the echocardiography is, number one, there will be right ventricular collapse because the right ventricle gets collapsed under the pericardial fluid, right? Then we can see pericardial collection or the effusion. Third, we can measure the intrapericardial pressure, intrapericardial pressure greater than 15 millimeters of mercury. We can also notice that the inferior vena cava is dilated because heart is having higher pressure, so less amount of blood is going to see how inferior vena cava drains the blood. In here we have the right atrium. Inferior vena cava has to take the blood from lower part of the body to the right atrium, but because the pressure here is high, it will not allow the blood to enter into the cardia easily. So inferior vena cava pressure becomes higher and it will become dilated. So we can have dilated inferior vena cava. So these are the echo findings that we can get. Should I write it for a 5-mark question? No. It's not expected from an undergraduate student to write the echo findings. You have time and you remember, you can recreate the points that I discussed. Otherwise, it's okay to omit. As long as you mention that echo or right heart catheterization can be considered as investigation of choice and ECG findings you are mentioning, it is more than enough. Now, if I had done the chest X-ray, not important, not recognized, but if I had done, how will it appear? Of course, I cannot diagnose cardiac tamponade on the chest X-ray. I can diagnose pericardial effusion. I will call it as cardiac tamponade only with the help of ECG and echo. But how that is going to look like? Now this is going to be my lung fields, right? In normal condition, this is where I will have the heart. So this is where I have the pericardial cavity. Now the fluid starts getting accumulating into this pericardial cavity. So when the fluid accumulates, what do you think? Will it accumulate more at the top? In this region, more fluid will accumulate, or more at the bottom? Where will the fluid accumulate more? Of course, gravity, right? Just think of it. Take a balloon, fill it with water, and then place it on a table. Right here we have the diaphragm. So this heart is resting on the diaphragm. So pericardial sac is just like a balloon. Now fill a balloon with water and keep it on the table. What do you think? It will spread out more at the bottom, right? So even pericardial sac, when fluid collects because of gravity, it collects more at the bottom and it is more spread out at the bottom. At the top, it is more narrow. So how is it going to look like? It will look like this, right? Because here I have fluid. So this is the cardiac silhouette, which looks like bottom it is widely spread out and on top it is relatively narrow. And we give a name for this description. What do we call it as? We will call it as money bag or water bottle heart. We will call it as money bag or water bottle heart. So why is it called as money bag or water bottle heart? You might have seen, if you know Hindi, you might well know. There is like potli, right? Like our elder aunt, like jo elder ladies hote the ghar mein, they used to keep coins in a small gunny bag, which is like potli. They used to keep all their coins. And in the Gulf region, they used to have a water bottle made of leather, which used to look somewhat like this. So heart kind of looks like that only. That's why it is called as money bag heart or water bottle heart. So that is our chest X-ray finding. So whatever sketches we have made today, they are all easily reproducible in the exam, right? This you can recreate comfortably in the exam. These ECGs you can recreate in the exam. This tamponade description you can recreate in the exam. And you can also recreate the JVP waveforms that we have done. Always try to be more visually communicative in the written examination than making lengthy sentences. Okay, MedNerd. Of course, because it's difficult, MedNerd, for me to think of a diagnosis without having done the examination. So any ENT doctor or a general physician nearby, you can definitely consult. Okay. So now we have written about the diagnosis, we have written the role of ECG, echo. Now it is the management, right? In the very beginning only we have mentioned that the cardiac tamponade is life threatening because if the cardiac output is less, BP will be low, and low BP means organ perfusion is impaired. Eventually organs will fail and the patient will die. So we need to save the patient as soon as possible, and of course we have to also save the organs, right? So how do I do? The management will primarily focus on, number one, Emergency pericardiocentesis. Good evening, average medico. Emergency pericardiocentesis. Now, what centesis means? Removing the pericardial fluid. Removing the pericardial fluid. Okay. Then there are several approaches. I can put a needle in the second intercostal space, fourth intercostal space, substernal approach. So you should mention which approach is preferred. Preferred approach. What is the preferred approach? It is the substernal, or it is also called as subxiphoid approach. Substernal or subxiphoid approach. We can put a simple sketch here for this. Okay, so this is a human being. Accept it. Okay, this is going to be his sternum. So this is where the heart is going to be there. So what we do is we pass the needle from the substernal side. From the substernal side, the needle will be passed for the aspiration. So we will call this as the subxiphoid approach. Again, a very easy to recreate image. You can tell the examiner without making him read whole sentence that you know which approach is preferred. Okay. Now the story of management doesn't end here. Why? Because what is the most common cause? Hemopericardium, right? Bleeding into the pericardial cavity. So if I put a needle and remove some blood comes out. But if there is an ongoing source of bleeding, it will reaccumulate again after some time, right? So this is the initial step. And then second thing you should mention is surgical window or exploration if trauma is the cause. Because if it is traumatic cardiac tamponade, in that case, it is mostly bleeding. So if I just put a needle and remove, temporarily, I am allowing the collapsed right ventricle to open up. Hemodynamic problems are temporarily solved, but it will rebleed again because if there is a continuous ongoing bleeding. After few hours, again patient will be in cardiac tamponade. So once I put a needle and remove the fluid, I have to hand over the patient to a surgeon to find out from where he is bleeding, and the next steps will be taken by the surgeon. So that completes our discussion on the cardiac tamponade. To give you a quick summary, what points you should mention in the definition? It is a condition where there is pericardial collection or fluid or effusion which has resulted in increased intrapericardial pressure, impaired ventricular filling, and cardiac output. Okay. Then causes, just mention hemopericardium and myxedema. Don't bother about mentioning any other causes from the long list in the books, not expected from you in the exam. Clinical features, just mention the Beck's triad. You don't have to beat around the bush beyond Beck's triad for the written exam. Pathophysiology is not expected if it is a 5-mark question. I wrote it just for our understanding. Diagnosis, ECG, I definitely want you to mention the electrical alternance and low QRS voltage complex. Electrical alternance is very important. The name is called as electrical alternance because alternating high and low voltage QRS complexes are there. Okay. Then just X-ray, try to do a visual representation with the money bag or water bottle. In terms of management, mention emergency pericardiocentesis is the initial step. Preferred approach is substernal. Try to visually represent the subxiphoid approach. And then mention that in selected cases, you might require surgical exploration. Okay. So the next question we are taking up is on atrial fibrillation. Almost every university paper will have one question on arrhythmias, and if they are asking a question on arrhythmia, it is most likely going to be atrial fibrillation. Among arrhythmias, atrial fibrillation is the most frequently asked theory question. Okay. So they will either ask you classify arrhythmias and then discuss about atrial fibrillation, or they will ask you discuss about atrial fibrillation and then write a short note on prevention of stroke in patients with atrial fibrillation. Right? We will address all those points. Okay, so we'll begin with the definition. What is atrial fibrillation? Atrial fibrillation is an arrhythmia. Okay, but how do we classify arrhythmias? Because sometimes the beginning or opening question is classify arrhythmias and then classify arrhythmias and then they will say like start talking about atrial fibrillation and start talking about ventricular tachycardia. So how do we classify arrhythmias? So first of all, we will understand what is arrhythmia. What is arrhythmia? The normal cardiac rhythm is sinus rhythm, right? Sinus rhythm. So what does that mean? So whenever they ask you about arrhythmias, you should begin by first defining normal sinus rhythm. What is normal sinus rhythm? For the normal sinus rhythm, who is the pacemaker of the heart? SA node is the pacemaker. SA node is the pacemaker of the heart. Okay. Second thing. Now, if SA node is the pacemaker of the heart, will I have the P waves? Yes. So normally what happens? SA node sends a signal acting as the pacemaker. This signal will go to AV node, and from the AV node the signal will travel through His bundle that will divide into two bundle branches, eventually to Purkinje fibers, and then goes to ventricles, right? So if SA node is the pacemaker, then the wave of electricity will also spread to the atria and cause the P waves. So the normal sinus rhythm should have P waves. P wave should be present. If AV node is the pacemaker, I may not have the P waves. But if SA node is the pacemaker, P wave should be present. Then third, what should be the relationship between P waves and QRS complex? Should the ratio be equal, or P wave should be more than QRS complexes, or QRS complexes should be more than P waves? When do you say it is normal? So when SA node sends one signal, AV node gets one signal. AV node sends one signal to the ventricle. So ventricle contract once. So when SA node's electricity passes through atria, I get a P wave. When it passes through the ventricle, I get a QRS complex, right? So then if there is one P wave, there should be one QRS. So we will call it as normal sinus only when every P wave is followed by a QRS complex. So essentially that means P is to QRS ratio is 1. If there is one P wave, there should be one QRS. If there is a P wave but no QRS, then somewhere there is a block in between. That's why the P wave could not reach the ventricle, right? Or if there are less P waves and more QRS, that means somewhere else there is an extra pacemaker in the ventricle. So they are all not sinus rhythms. Then the fourth point to call it as normal sinus rhythm is heart rate should be in the range of 60 to 100. If all these points are met, we will call it as sinus rhythm, normal sinus rhythm. If any of them is not met, then it is not normal sinus rhythm, then we will call it as arrhythmia. Let us say that I have a condition where SA node is the pacemaker. Okay, there are P waves present. Every P is followed by a QRS. P to QRS ratio is 1, but heart rate is 40. Then it is not normal sinus rhythm. Rhythm is sinus, but not normal. Then what we will call it as? We will call it as sinus bradycardia. If the rate is more than 100, we will call it as sinus tachycardia. Sinus bradycardia, sinus tachycardia are not normal sinus rhythm. They are also arrhythmias. So how will I now classify arrhythmias? Arrhythmias are classified into two groups, bradyarrhythmias and tachyarrhythmias. So those conditions where this is not satisfied, these parameters are not satisfied, are called as arrhythmias. And based on the heart rate in those arrhythmias, we will classify them as bradyarrhythmias and tachyarrhythmias. So what comes under bradyarrhythmias? So under bradyarrhythmias, we can have sinus bradycardia, where the pacemaker is sinus rhythm, sinus node, but the heart rate is lesser than required. So we'll call it a sinus bradycardia. Second, sinus node functions well, sends an electrical impulse, but AV node fails to pass it on to the ventricle. So in that case, what do we call it as? AV blocks, atrioventricular blocks or AV blocks. You may be familiar with the first degree AV block, second degree Mobius type 1, Mobius type 2, and third degree AV block. Okay. Then what else can be there? SA node sends a signal, but it is not able to leave the SA node to go to AV node. So it is just getting lost in the SA node itself. So in that case, we will call it as SA blocks. So block can be there at the SA node level. It can be there at the AV level. So these are causes for bradyarrhythmias. Now the tachyarrhythmias, we will divide them into two broad groups. we will divide them into two broad groups. Means heart rate more than 100, rhythm is not coming from the sinus. So we will divide them into narrow QRS tachyarrhythmias. Narrow QRS tachyarrhythmias. Now, what do I mean by that? The QRS complex that we see, right? QRS, its width or duration is narrow. So, again, those who don't know, what is the normal QRS duration? Normal QRS duration is 80 to 120 milliseconds. 80 to 120 milliseconds. So on the ECG, one small square, right? You know, ECG has these large squares, and within that large squares, we will have 5 small squares, right? So one small square in terms of time represents 40 milliseconds. So your QRS complex normally is supposed to take 2 to 3 small squares at max. So if it is taking more than 3 small squares, we will call that QRS as wide. Like if the QRS starts here and then it is taking more than 3 small squares, like I represent it here, it is taking more than 3 small squares. So then it is wide. So when the QRS duration is normal, then such arrhythmias less than 120 milliseconds, such arrhythmias we will call it as narrow QRS tachyarrhythmias. And if the QRS duration is more, then we will call them as wide QRS complex tachyarrhythmias or wide QRS tachyarrhythmias. So where the QRS duration is more than 120 milliseconds. Okay, so what are the examples for the narrow complex tachyarrhythmias and what are the examples for the wide complex? So the first example is sinus tachycardia. Sinus tachycardia is the narrow complex tachyarrhythmia. Second example is paroxysmal supraventricular tachycardia. Then you have multifocal atrial tachycardia. Then you have atrial fibrillation. These are few examples you can write. And for the wide complex tachycardias or tachyarrhythmias, what are the examples we have? We have ventricular tachycardia and ventricular fibrillation. There are also some rare variants like aberrant conduction and not required for an undergraduate student, at least in the theory exam. MCQ ke liye we will see later. So this is the classification I want you to replicate when they ask you to classify arrhythmias. Brady. In Brady, we have sinus bradycardia, blocks in AV node, blocks in SA node. In tachy, based on the QRS duration, whether it is normal or wide. If it is wide, VT and VF. If it is normal, it could be sinus tachycardia, PSVT, MAP, and atrial. So after the classification, we will start with the atrial fibrillation, which is the most commonly asked arrhythmia for the written exam. So what is atrial fibrillation? I forgot to mention one point. The narrow complex tachyarrhythmias are usually, supraventricular. Means the origin of this arrhythmia is above the ventricle. Means the rhythm becomes disturbed at the level of atria. And wide complex are usually ventricular. These are usually ventricular. These are ventricular and this is usually supraventricular. Another way of classifying the arrhythmias is same, ventricular and supraventricular. So atrial fibrillation is which type of arrhythmia? In that case, is it ventricular or supraventricular? Atrial fibrillation is a narrow complex tachyarrhythmia. So that means it is a supraventricular arrhythmia. The arrhythmia originates in the atria, not in the ventricle. That's why we are calling it as atrial fibrillation. Right? So in the definition, what will I write? The first word you need to mention in the definition is that atrial fibrillation is a supraventricular tachyarrhythmia. Now, how is it different from all other supraventricular tachyarrhythmias? It is characterized by uncoordinated atrial activation. Atria is contracting not with the usual rhythm but irregularly. Irregularly it is contracting. Okay, so what do I lose if it is irregularly contracting? It is not contracting with sufficient force so that it will push the blood to the ventricle. Atria's job is to contract to push the blood to ventricle. It is not able to do that. So these contractions are ineffective. These are ineffective atrial contraction. So how will I recognize it? And what is the problem that I will face if the atrial contraction is ineffective? I'll discuss that. But first, how will I recognize it on the ECG? So ECG, the first feature you should mention on the ECG, that the QRS duration is going to be less than 120 milliseconds. Why? Because it is a narrow complex tachyarrhythmia. That is first thing. Second thing we should mention is that because there is uncontrolled or uncoordinated atrial activation with ineffective contraction, I will not have proper sized P waves. So normally how the ECG looks like, I will have a P wave, then a QRS complex, T wave, then again a P wave, a QRS complex, and then a T wave. These P waves have some reasonable amplitude or voltage, because that voltage is sufficient for the atria to contract. But if I give them insufficient voltage, they will not be able to contract. So I will have very small, barely recognizable P waves. Small, barely recognizable P waves. So what will I call them as? I will call them as fibrillatory waves. We will call them as fibrillatory waves. So no clearly identifiable P waves. There will be no clearly identifiable P waves. And those small tiny baseline undulations, the very minimal voltage that is circulating through the atria, that we are going to call it as fibrillatory waves. There will be fibrillatory waves present, but no P waves, morphologically distinct P waves. So the normal ECG is going to look somewhat like this. Normal ECG is going to look like a proper identifiable P wave, QRS complex, right? T wave, P wave, QRS complex. So this is the normal ECG. How atrial fibrillation is going to look like? First thing, you will not have a clearly identifiable P wave. So you will have some baseline undulations. So these baseline undulations, you will call them as fibrillatory waves or F waves. Fibrillatory waves, or you can also write them as F waves. After that, the QRS complex will be narrow only, like normal. It will be narrow only. The last and important point that you have to mention is that these QRS complexes are not regular. So here it is coming at regular interval. Here it will be irregular. Irregular RR interval. Irregular RR interval. So you can sketch like this, showing that the RR interval is irregular. Sometimes it is coming early, sometimes it is coming late. So you can mention that there are fibrillatory waves, then there is varying or irregular RR interval. So this is our RR interval, and you can label it saying that there is varying RR interval. So this is a decent pictorial representation of the ECG findings that we will get in the atrial fibrillation. In fact, you open Google, most of the ECGs are going to look kind of like this one, right? Irregular rhythm. So that is the ECG features of atrial fibrillation. Now, what can cause atrial fibrillation? What are the causes for atrial fibrillation? Okay, so first thing we should mention as the cause. Have you heard of this condition called as holiday heart? So alcohol is known to trigger atrial fibrillation, and we call it as holiday heart syndrome, because during holidays people drink heavily and then they may end up with palpitations and atrial fibrillation. So we'll call it as holiday heart syndrome. Okay. Too much caffeine can also be a cause for atrial fibrillation. Caffeine. Okay. Then third, ischemic heart disease, any structural damage to heart. Fourth, any condition that causes left atrial enlargement. Anything that left atrial enlargement can happen because of mitral stenosis, or because of left ventricular hypertrophy, or because of mitral regurgitation. In all these cases, we can have the risk of developing atrial fibrillation. Okay. Then fifth, something called as pre-excitation syndromes, where there is accessory pathways present which can result in
increased risk of arrhythmias. An example for that we can quote is WPW syndrome, Wolff-Parkinson-White syndrome. It's a well-known risk factor for atrial fibrillation. So these are the important causes for atrial fibrillation. Okay. What examiner is looking for? Mostly alcohol and caffeine. Okay. And sometimes it can be without a structural heart disease in elderly. Heart disease, it can occur in elderly without any structural problem with the heart. In such cases, you should remember it is called as lone atrial fibrillation, lone AF. Sometimes in the Viva OSCE examiners do ask you, what do you mean by lone AF? The development of atrial fibrillation without having any structural abnormalities, no ischemic heart disease, no left atrial enlargement, no pre-excitation syndrome. In elderly, if it happens, we call it as lone AF. Means only AF comes, no other problems are there, but still AF comes, lonely. That is lone AF. Okay. The next thing I want you to write is, how do you classify the atrial fibrillation? There are different classifications of atrial fibrillation, but the one that we should be familiar is based on the duration. Now, can I live with ventricular fibrillation for like few months? No. Why? Because what is the meaning of fibrillation? Ineffective contraction, just shaking. Right? Every time you talk about atrial fibrillation, what should come to your mind? Atria is shaking, not contracting. So it is not able to push the blood. This atria, which is supposed to push the blood to the ventricle, it is not able to do because it is not contracting. It is supposed to contract, but it is instead merely shaking. Fibrillation, think of shaking. Ventricular fibrillation means ventricle is only shaking, it is not contracting. If atria doesn't contract, it's not a big deal. Why? Because the transfer of blood from atria to ventricle largely happens through passive filling. We are not totally dependent on atrial contraction. Only 20% of transfer happens because of atria contract. 80% comes passively. But ventricular ejection is all active. If ventricle doesn't contract, no ejection. No ejection means no cardiac output. No cardiac output means nothing goes to brain, and within few minutes your brain is gone. So we cannot survive with ventricular fibrillation for long. That's why ventricular fibrillation is a cardiac emergency. We need to start CPR. But can I survive with atrial fibrillation? Let me have atrial fibrillation for months, years together. Yes, possible. Right? So atrial fibrillation is among those few arrhythmias where chronicity is possible. VT cannot be chronic. VF cannot be chronic. But AF can be chronic. So based on the duration, atrial fibrillation is classified into 4 groups: paroxysmal, persistent, long-standing persistent, and permanent. Right? We will understand what are those. Paroxysm means what? Intermittent. So if there is an episode of atrial fibrillation, that gets terminated or normalized within 7 days, spontaneously, without any cardioversion or pharmacotherapy, then we will call it as paroxysmal atrial fibrillation. Like, okay, I was doing gymming, I started getting palpitations, I went to the hospital, the duty doctor did the ECG, he said that there is atrial fibrillation. Before he even thinks of getting me some drugs, it's settled. That is our paroxysmal atrial fibrillation. So what is persistent atrial fibrillation? AF lasting for more than 7 days, or AF that required pharmacological or electrical cardioversion. Means I got a AF, I went to the hospital, and it did not revert spontaneously. Doctor had to give me amiodarone or had to give me shock. Then my arrhythmia went away. Then it will be called as persistent AF. Similarly, atrial fibrillation that is lasting for more than 7 days, even after 7 days, if it goes spontaneously also, it will be still considered as persistent AF. Okay, then what is long-standing AF? The AF lasting for more than 1 year. For more than 1 year is called as long-standing AF. So less than 7 days is paroxysmal. More than 7 days or anything that required shock or drugs is persistent, and anything that is lasting for more than 1 year, that will be called as long-standing persistent. And what is permanent AF? Now, many patients in the AF
it is not possible for us to get their rhythm back to normal. Like we give drugs, we give shock, nothing works. Eventually, what happens is that we give up as doctors. Like we give up, saying that it's not possible for you to get your sinus rhythm back. You live with atrial fibrillation. We'll try to help you with other medications to minimize your symptoms. Such state is called as permanent AF. So, what is permanent AF? AF where normalization of rhythm is not pursued, means we are not pursuing anymore to convert the rhythm to normal sinus. We have given up. Then we call it as permanent AF. So these are the types of atrial fibrillation. Okay. Now, what clinical features a patient of atrial fibrillation will present? For any arrhythmias, you are going to write these 4 symptoms. Whether it is VT, PSVT, atrial fibrillation, whatever it is, write these 4 symptoms. What palpitations? Heart is beating at very high rate, they will feel palpitations. Okay. If heart is beating at very high rate, the cardiac output will come down, they will feel fatigued. Okay. They can have shortness of breath. And if the cardiac output is low, sufficient blood doesn't go to brain, they can have syncope. For all arrhythmias, 4 symptoms standard, write the same thing. In terms of clinical examination, I want you to write 2 extra points for the atrial fibrillation. Now look at this ECG. What do you think will be the pulse? Will the pulse be regular? No, ventricular contraction is happening irregularly. So pulse will also be irregular. So we will have irregular pulse. Pulse is usually described as irregularly irregular. Irregular pulse. Okay. And then in the atrial fibrillation, you are expected to write about something called as pulse deficit. What is pulse deficit? Pulse deficit refers to, pulse deficit is equal to difference between simultaneously measured heart rate by auscultation and pulse rate by palpation. So if simultaneously one person auscultates and calculates your heart rate based on the beats, and another person palpates and calculates your pulse rate, we are measuring both simultaneously. In an ideal circumstance, there should be no difference. But of course, there are human errors, so we get some minor difference. If a person measuring heart rate, he says 100, person measuring pulse rate may say 96, 97 or 102, 103, that's fairly okay. But if the difference is more than 10, then we say there is increased pulse deficit. Otherwise, it is less than 10, it is considered as normal pulse deficit. So pulse deficit is increased in atrial fibrillation, that is usually more than 10 per minute. It's again a very, very important point to write in the theory exam for atrial fibrillation. So how do we make a diagnosis of atrial fibrillation now? We know the clinical features. The diagnosis is of course ECG based. I am not writing the features again because earlier only we have discussed the ECG features of the atrial fibrillation, right? Okay, but apart from ECG, we also have to do a 2-dimensional echocardiography. Why is it important for a patient with atrial fibrillation? That too, transesophageal echo is preferred. But why are we doing it? For 2 reasons. Number 1, to assess left atrial size. I have already told you, whenever left atrial enlargement happens, it can become a reason for atrial fibrillation. And second, if there is any clot in the left atrium, presence of left atrial clot. I will tell you the details of it, why I am looking for a clot in the left atrium in a bit. But for these 2 reasons, in addition to ECG diagnosis, I also need to do the echo. Now, why clot is a big deal? Now, what is happening here? The left atrium is not contracting. It is merely shaking. So, whatever the blood I have in the left atrium, so there is a left atrial appendage which is more posteriorly present and inferiorly present. There will be some amount of blood which starts stagnating if left atrium does not contract. If it contracts, it pushes all the blood to ventricle, but here it is only shaking. So there will be stagnation of blood in the left atrium. And there was a great person called as Virchow who had said that 3 things are at three things put us at increased risk of developing a clot. What are those? Endothelial injury, hypercoagulability, and stasis. That is what we call as Virchow's triad, right? What are those? Hypercoagulability, endothelial injury, and stasis. So here, by atria not contracting, it is allowing the blood to become stagnant or stasis. So it will form a clot. And once there is a clot, from the left atrium, where this clot can go? Left atrial clot is a possibility. Where it can go? From the left atrium, only route it can go is to the left ventricle. And from the left ventricle, where it can go? To the aorta. And from the aorta, most likely where it will mostly go into the carotid artery. From the carotid artery straight to the brain. And it can become a reason for stroke. So I should definitely know whether there is a clot in the left atrium or not. Because if there is a clot, it can put the patient at risk for stroke. This is a very important point when it comes to management of atrial fibrillation. So that's why whenever we have made a diagnosis of atrial fibrillation, whether I should convert the rhythm to normal or not has to be decided first. Why that is important? Because if the duration of this atrial fibrillation is more than 48 hours, 48 hours of time is sufficient for the clot to form. And in such case, I convert the rhythm to sinus. Earlier it was not contracting. It was only shaking. So it was actually kind of protecting this clot from going to the ventricle. But now that the atria started contracting, it will push the clot into the ventricle if I convert the rhythm to sinus, and it will embolize. So if there is a left atrial clot, converting atrial fibrillation to sinus puts increased risk of stroke to the patient. So that is why once we have made a diagnosis of atrial fibrillation, for the management, first thing we have to look at is the duration. If it is more than 48 hours, then it is clearly at risk of stroke. If it is more than 48 hours. If it is less than 48 hours, then probably clot will not be there. So in that case, you can comfortably convert the rhythm to sinus. If it is less than 48 hours, we will go with rhythm correction. Correct the rhythm to sinus, from atrial fibrillation to sinus with drugs or the shock, depending on patient status. But if it is more than 48 hours, or definitely I don't want to take risks, so even in those cases where the duration is unknown, whether it is more than 48 hours or unknown, there is a possibility, right? In both these circumstances, there is possibility of left atrial clot that needs to be ruled out. Possibility of left atrial clot. So how do I rule that out? By doing a transesophageal echo. So I have to do something called as transesophageal echo. Why am I preferring the transesophageal echo? Remember, if you have cut the chest and seen the heart in the dissection table, you know that you will barely see only a small portion of the left atrium anteriorly. Right atrium is clearly visible because left atrium is more posteriorly positioned. So when we do transthoracic echo, I will not be able to visualize that portion where clot is likely to form. So that's why to see that area of the left atrium, I put the echo probe into the esophagus, go near the heart, and through the esophagus, I will be able to visualize this posterior part. That's why transesophageal echo is preferred. If I do a regular thoracic echo, I may miss the clot, right? So once the transesophageal echo is done, if there is a clot present, right, then I should not convert the rhythm to sinus, right? If there is no clot, then nothing is stopping me from converting this patient's rhythm to sinus. So I will go for the rhythm correction. But if there is a clot present, then step number 1, we have to start anticoagulation. Because there is a clot, I want to wait till the clot dissolves, right? Generally it takes for 3 weeks for the clot to dissolve. And step number 2, till I achieve the anticoagulation and I'm sure that the clot is dissolved and now I can convert the rhythm to sinus, till that time we have to follow what is called as rate correction or rate control. Means let the patient be in atrial fibrillation, let his atria keep vibrating, not contracting, so that the clot doesn't get pushed. But the overall heart rate I want to bring down. Then step number 3, once clot dissolved, then I can go for the rhythm correction. Now I can put the patient's rhythm to sinus.
But as long as clot is there, I should not be doing that, right? Okay. Now the question is, I understood what is rate correction and what is rhythm correction. Rhythm is converting the rhythm to sinus. Rate correction is just controlling the rate, not touching the rhythm. Let it be in atrial fibrillation only. And we know the objectives behind that. How do I achieve that? How do I achieve the rate and rhythm correction? Okay, just give me a second. How do I achieve the rate or rhythm correction? The approach is going to be very important for us to replicate in the exam. Approach to rhythm correction. So once patient is ready for rhythm correction, if it is a case of atrial fibrillation, first thing I should see is patient's BP, whether patient is hemodynamically stable or unstable. And this applies to all arrhythmias. Any arrhythmias, once you have decided that I need to treat, first thing that we should see is what is the BP. If patient is hemodynamically unstable, for all arrhythmias, there is only one trick: shock, shock, shock. But if patient is hemodynamically stable, then physical maneuvers, drugs will be tried. When they fail, then only we come to shock. So what we will do, once we are ready for rhythm correction, we will look at the BP. If it is more than 90/60, if it is more than 90/60, we will do pharmacological treatment. And if it is less than 90/60, only shock. So more than 90/60, the treatment is pharmacotherapy. What drugs we can use? The currently considered drug of choice is amiodarone. Amiodarone. Alternatively, what other drugs can be used if amiodarone is contraindicated or not available? Other drugs that we can use includes non-dihydropyridine calcium channel blockers like verapamil, diltiazem, or we can also use procainamide. Procainamide. These are the drugs that we can use for converting the rhythm, pharmacological rhythm conversion or pharmacological cardioversion. But if BP is low, only shock. And we know that there are two types of shock: cardioversion and defibrillation. Please don't fall for this word कि हाँ atrial fibrillation है तो we will do defibrillation. No. Defibrillation type of shock is used for only two conditions. What are those? Ventricular fibrillation and ventricular tachycardia without pulse. Without pulse. Pulse is not felt. Only in these two circumstances we go for defibrillation. For all other arrhythmias, if BP is low, we go for what is called as cardioversion. Now, what do we do in cardioversion? We give the shock to R wave. Means shock is delivered precisely to the R wave. That is cardioversion. In defibrillation, we give shock just like that. Means we don't see whether electricity is touching the R wave or whether the electricity is going to P wave. Just shock. In cardioversion, shock is given only to R wave. So here BP low and we have to treat it with cardioversion. Cardioversion. Okay, clear? This is going to be the approach. So if the duration is less than 48 hours, directly I am taking this step, right? Directly we are going for the cardioversion algorithm. But if duration is more than 48 hours or unknown, we will check the transesophageal echo. No clot, I go for rhythm correction. Clot present, I start anticoagulation, and once the clot goes away, then I can come to the rhythm correction, right? Till that time, I'm not jumping to the rhythm correction. Okay. The next thing they will ask you is what are the complications of atrial fibrillation? Complications of atrial fibrillation. The first and the most important complication one should mention that we have already discussed is the stroke. First one is stroke. Right, we can call it as cardioembolic stroke because a clot is formed in the heart and then going to the brain. We will call it as cardioembolic stroke. What else it can cause? Hypotension, shock, and death. Hypotension or shock. And the third, it can become a reason for death. So these are the complications. Now, one of the template of asking questions is that can we predict the risk of stroke in a patient with atrial fibrillation, and if we can predict, how we can prevent, right? So the risk can be predicted with an algorithm called as CHA2DS2 VAS. Higher the score, higher is the risk of stroke, right? So the stroke prediction, stroke prediction is done through a score called as CHA2DS2 VASC score. This is a mnemonic in itself, so easy to remember, no need to worry about it. What it says, C in the CHA stands for congestive heart failure. Okay. H stands for hypertension. Then A stands for age, more than 75 years. And why am I labeling it as A2? Because age more than 75 years, I am giving 2 marks or 2 points. Okay. Then D here stands for presence of diabetes. S stands for stroke. Why again I am labeling it as S2? Because presence of previous stroke, I will be giving 2 points for the patient. V stands for vascular disease, like peripheral vascular disease, coronary artery disease, already existing vascular disease. Okay. The next A is again age, but not 75 plus, but instead 65 to 74. I will give only 1 point. And the last one is the gender or the sex of the patient. For which sex category? SC VASC stands for sex category. For females, we are giving 1 point. Okay, so in itself, it is a mnemonic. It is easy to remember. Right, replicate it, and we already know where to give 2 points. Now, how do I prevent? Prediction done, right? Stroke prevention in a case of atrial fibrillation. Stroke prevention. It is based on the CHA2DS2 VASC score. So, if the CHA2DS2 VASC score is more than or equal to 2 for males and more than or equal to 3 for females, more than or equal to 3 for females, it calls for treatment with, we need to start anticoagulants, start anticoagulation. Otherwise, the clot will be formed and they will end up with the stroke. Now, how do I remember these numbers? Only one thing you have to remember, right? We are actually not giving any value to this gender number. Just eliminate the gender. So, everyone, whether it is male or female, if you cut the sex category score, then everyone is supposed to have 2 or more than 2 points, and then it commands the initiation of anticoagulation. Okay. So, that is about the complications of atrial fibrillation. So, I think if you, as long as you remember CHA2DS2 VASC score and the rhythm correction algorithm and ECG features of atrial fibrillation, you will be getting 3+ marks for sure if it is a 5 marks question. Okay. So next up, we are going to another arrhythmia question, which is about ventricular tachycardia. Write about emergency management of ventricular tachycardia. So mostly this question will open with like this. Classify the arrhythmias, write about the management of ventricular tachycardia. Or sometimes it's like discuss how do you differentiate between ventricular tachycardia and ventricular fibrillation on the ECG, write about the management of ventricular tachycardia. Okay. So what is ventricular tachycardia? As the name says, it is a tachyarrhythmia and the origin is not supraventricular, not atria, it is originating in the ventricle. So ventricular tachycardia is a tachyarrhythmia originating in the ventricles. This is the conceptual definition. Now what is the objective definition? So remember guys, normally who is the pacemaker of the heart? It is the SA node, right? Ventricles, his bundle or the bundle branches, Purkinje fibers, can they become the pacemaker? Agar zaruri hai to they can become the pacemaker. If SA node fails, AV node fails, some part of the ventricle can become the pacemaker. So if something in the ventricle becomes a focus, right, and sends an impulse for ventricular depolarization, ventricle may contract in addition to the regular contractions that are coming from the normal conducting path. So those extra contractions are called as premature ventricular contractions. Right? You can also call them as VPCs, ventricular premature contractions. Occasionally it happens even in normal individuals, especially when you are under too much of alcohol or too much of caffeine. Sometimes you feel like you missed a beat. Those are all the feelings of appearance of premature ventricular contractions. But if 3 premature ventricular contractions come in succession, then we can call it as ventricular tachycardia. How do I recognize a premature ventricular contraction? The ventricular premature contraction will be wide complex. Wide complex means the QRS complex is, if normally it is narrow, less than 120 milliseconds, the premature contraction will be more than
120 milliseconds. So you will have wide QRS. So if I have successive 3 wide QRS complexes appearing in an ECG, then it is a ventricular tachycardia. So that's why the objective definition goes like this. Ventricular tachycardia is equal to 3 or more than 3 consecutive or successive premature ventricular contraction. Now, how do I classify the types of ventricular tachycardia? There are two ways of classifying it, either based on duration or based on how the QRS complexes appear. Based on duration, we classify ventricular tachycardia into sustained and non-sustained. But remember, atrial fibrillation, we classified them as, how did we classify the atrial fibrillation? We had the 4 categories: paroxysmal, persistent, long-standing persistent, and permanent. VT, of course, it will not be living, you won't be living with VT for like days together. So it is always a very short duration arrhythmia. After that, either it should be terminated or you are terminated with that arrhythmia. We cannot coexist with VT for forever. So VTs, we classify them into sustained. Sustained when it lasts for more than 30 seconds. Means the ventricular premature contractions continuously happen for more than 30 seconds. We will call it as sustained VT. And when it is living for less than 30 seconds, like only 5-6 beats were abnormal and then again it all became normal, then we will call it as non-sustained ventricular tachycardia. Okay. There is another classification which is based on the morphology. Okay. So remember, we have learned about the classification of arrhythmias. Right? We have classified them into narrow complex and wide QRS complex. So where do I get VT? VT is a wide QRS complex tachycardia. So the QRS will be wide, more than 120 milliseconds. So those wide QRS complexes, based on how do they look in relation to other QRS complexes, we will classify the ventricular tachycardia into 2 broad groups: monomorphic VT, monomorphic ventricular tachycardia, and the second one is polymorphic ventricular tachycardia. Polymorphic ventricular tachycardia. We will call it as monomorphic ventricular tachycardia if there is a tachyarrhythmia or a tachycardia with wide QRS complexes with similar QRS morphology in a given lead. Similar QRS morphology in a given lead. I will explain what does that mean. So let us say that there is one lead we have taken and I'm looking at QRS complexes. They are wide and heart rate is more than 100. So I know it is one of the tachyarrhythmia. And then the QRS complexes all look same. The next one is same, the next one is same, the next one is same. Again, I want you to remember that from lead to lead, there may be difference because in a normal condition itself, from lead to lead, QRS complexes look different. But in a given lead, एक lead पकड़ो और उसमें if all the QRS complexes look same, the morphology is same, then we will call it as monomorphic. What happens in polymorphic? Polymorphic is a tachyarrhythmia with wide QRS complexes, but the QRS morphology is varying from beat to beat in a single given lead itself. Whatever lead you take, there is variation in the morphology. With varying QRS morphology in a given lead, varying QRS morphology in a given lead. So for example, if like take one lead and then one QRS looks like this, the other QRS looks like this, the QRS morphology is not same, it is varying, then we will call it as polymorphic. Varying morphology, we will call it as polymorphic. And there is a subtype of this polymorphic VT, subtype of polymorphic VT, where there is varying QRS morphology and it is going to kind of look like this. The QRS morphology is not same. One is larger, one is smaller, larger, smaller. And in such case, if I draw a line in the center, it looks like the QRS complexes are going above and below, oscillating above and below the baseline. Such arrhythmia, if you want, you can make it look like a waveform, right? Such arrhythmia is called as Torsades de Pointes. Torsades de Pointes is a subtype of polymorphic VT. We will call it as Torsades de Pointes. Torsades
D pointis
or TDP. It is a subtype of
ventricular polymorphic ventricular tachycardia, where QRS, like you look, take this is one lead we are looking at. This QRS is different from this. This is different from this. This is different from this.
so the morphology is varying.
And an imaginary line drawn at the center makes it look like a waveform that we used to sketch in physics classes.
So such thing is called as Farre Series D points.
Okay. So these are the classification of ventricular tachycardia. These patients will present with what clinical features? Same for every arrhythmia. They will present with palpitations, syncope, fatigue, right? Chest pain. You can write the same things for any arrhythmia as such, because the symptoms are going to be similar. Okay. How will I make a diagnosis? Of course, based on the ECG. What features I will get? First one, wide QRS complexes. That means QRS duration is more than 120 millisecond, right? Of course, tachyarrhythmia, so the heart rate will be more than 150 per minute, usually 150 to 250. Okay. Third thing,
It's a bit difficult for us to understand conceptually right now. We will omit it because it's for the theory exam. But I want you to write 2 points.
what is it? There is something called as capture beats and fusion beats. Capture beats and fusion beats.
Just write it for the exam. And no need to think about the concept behind it or how do they look on the ECG and all. As long as you're writing these 3 points, your ECG description of ventricular tachycardia is done.
Now coming to its management, how do I manage a case of ventricular tachycardia?
Ventricular tachycardia can be a reasonable emergency. Why? Because ventricle is contracting at very fast rate. Right? So when I increase the rate, the time available for filling of the ventricle goes on decreasing, because I have to accommodate 200 beats in 1 minute. Then I have less time for filling the ventricles. So if I have less time, I fill the ventricle less, I eject less, cardiac output can be low, I can develop into hypotension. And every time there is an arrhythmia with hypotension, there is a risk of death and it has to be treated with shock.
So if you have VT, how do we approach? Right. So VT will be classified into two broad groups. VT with pulse and VT without pulse. If there is a ventricular tachycardia and patient pulse is not felt, right, it is a damn big emergency. So how will I deal with these patients? Step number one.
If someone doesn't have pulse, right, is his brain getting perfused? No, right? So if there is a pulseless ventricular tachycardia and patient is unconscious,
we need to start CPR if patient unconscious. So no pulse and unconscious also,
immediately we need to start CPR, otherwise the brain will be gone within next few minutes, right?
Then step number two is the definitive treatment. And what is the definitive treatment?
I've already told you, only two conditions we give defibrillation. One is ventricular fibrillation, other one is VT without pulse.
So here we go for defibrillation as soon as defibrillator is available. Defibrillator is available. Even if you don't write a sentence, it's okay. Just mention defibrillation is the treatment of choice for VT without pulse. And till you defibrillate, you have to keep doing the CPR to keep the brain alive. But if it is VT with pulse, then we have to see whether patient is hemodynamically stable or unstable. So if the BP is less than 90/60, remember I have already told you, if BP is less than 90/60, always shock.
Rohina Rashid, the time taken for ventricular depolarization to happen is increased, right? That's why the QRS has become wide. But the gap between one depolarization to the next depolarization, the time spent in repolarization is shortened. So that is how we end up with the tachycardia. Okay. So when BP is less than 90/60, shock. What type of shock here? Defibrillation or cardioversion? I've told you, defibrillation only two, VF and VT without pulse. VT with pulse, no defibrillation. We will go for cardioversion. For every other arrhythmia, it is cardioversion. And if BP is more than 90/60,
then it will be treated through pharmacotherapy. Means you can give drugs. And what is the drug of choice? Drug of choice for VT currently is amiodarone. Amiodarone. Alternatively, we can also consider using lignocaine. Lignocaine can also be used, especially when it is associated with ischemic heart disease. Patients with MI develop a VT, lignocaine can be preferred over amiodarone. Currently, for most circumstances, we just use amiodarone. Okay, so this is our approach to the management of ventricular tachycardia. Okay. Now, the one last thing I want to add here is that many people are at increased risk of VT and it is predictable. And in such cases, we have to consider prevention of ventricular tachycardia, because ventricular tachycardia can be life threatening. It may push you into CPR in no time, right? So what are the high risk conditions and what is the preventive strategy, right? High risk conditions for VT. And for that matter, same applies for the ventricular fibrillation. So what are those? First one. Okay, how many of you have heard that some athlete or young individual while gymming or doing some physical activity suddenly collapsed and died? What is the most common cause for death in those patients? It is hypertrophic obstructive cardiomyopathy. But why did they die? It's not because of obstruction. They died because they developed ventricular tachycardia. So hypertrophic obstructive cardiomyopathy, right? Second, patients with ischemic heart disease with low ejection fraction, EF less than 35%. Okay. Third, patients with arrhythmogenic right ventricular dysplasia, right? Then patients with structural heart disease. If you have some abnormal cardiac chambers, these are all at increased risk of developing ventricular tachycardias. Then patients with long QT syndrome. Some people are born with channelopathies where the QT interval is long. That puts them at increased risk of developing Torsades deep pointers, another subtype of ventricular tachycardia. So for all these patients, how do we prevent? Prevention. What are the preventive strategies in them? So we can consider using drugs like beta blockers, which can reduce the sympathetic activity to some extent. And the second choice we have is ICD. What is ICD? ICD stands for implantable cardioverter defibrillator. Implantable cardioverter defibrillator. So we'll implant a shock machine in the patient's body itself, so that if a VT or ventricular fibrillation happens, it will shock accordingly, right? It will analyze the rhythm, decide whether it should be cardioversion or defibrillation, and it will shock accordingly. So those are the preventive strategies we have for all these patients at risk. These are the patients who are at risk of ventricular tachycardia. Okay. Now another 5-mark question that we can get from the arrhythmias is the paroxysmal supraventricular tachycardia. So in the paroxysmal supraventricular tachycardia, description of it will get 1 mark. Then ECG description or diagnosis will get 1 or 2 marks, and the management will get 2 to 3 marks. Okay. So what is this paroxysmal supraventricular tachycardia? Based on our understanding of classification of arrhythmias, it is one of the narrow complex tachyarrhythmia or a supraventricular arrhythmia. So PSVT is not just an individual entity, it is a group of tachyarrhythmias that originate above the ventricles, means supraventricular arrhythmias. And they are usually characterized by sudden onset and sudden termination. That is why it is called as paroxysm. Paroxysm means intermittent, suddenly comes, goes away. So these patients' usual story is that I was doing something, suddenly I had palpitations, it stayed for a few minutes, maybe half an hour, and then it disappeared. And again, after a few days, few months, it will come. So intermittently, it keeps coming. That's why it is called as paroxysm. Paroxysmal supraventricular tachyarrhythmias. Why am I using a term group here? Because there are subtypes like AV reentrant tachycardia, AV nodal reentrant tachycardia. So there are a lot of subsets. Subsets are not important for your theory exam. They will discuss the subsets when we talk about MCQ based exams. For now, just use the term group. If you want to write, you can say that in the bracket AVRT, AV, NRT. These all come under paroxysmal supraventricular tachyarrhythmias. What clinical features these patients will present with? Just like any other arrhythmias, same symptoms: palpitations, fatigue, syncope, chest pain, These are the usual symptoms. Now, how will I diagnose this PSVT on the ECG? Now, I forgot to mention the causes. We will talk about the causes and then we go to the diagnosis. Same things that you mentioned for atrial fibrillation, we can mention here. The first one is alcohol. Alcohol can trigger PSVT. Second, caffeine can trigger PSVT. Then third, sepsis. Lot of patients in the ICU end up getting PSVT, like they're admitted with urinary tract infection, they go into sepsis. Body produces a lot of inflammatory cytokines. These cytokines will go and cause damage to the myocardium, make it become a little abnormal conducting. Then we can have PSVT. So sepsis. Then fourth, pre-excitation syndromes like WPW syndrome, like WPW syndrome. Then fifth, electrolyte abnormalities. And sixth, dehydration. So even dehydration or hypovolemia is known to trigger PSVT. So these are all the causes for PSVT. How will I diagnose it on the ECG? So the most common PSVT description of the ECG is first one. ECG will show what kind of QRS? Narrow QRS, because it's a supraventricular arrhythmia, means QRS duration less than 120 milliseconds. Okay. Then second, here the P waves are not identifiable. So you will have absent P waves, absent P waves. And the third, the RR interval, unlike atrial fibrillation also P waves are not clearly identifiable. Here also not identifiable. Atrial fibrillation is also narrow complex. This is also narrow QRS complex. What differentiates between the two? Here it is the RR interval which is going to be constant. It will have constant. It is not varying from beat to beat. We will have constant RR interval. You can make a small sketch representing the points that we discussed. You can say that you can write one normal looking ECG and you can write one like normal will have identifiable P wave, then QRS, T wave, then P wave, then QRS, then again T wave, right? You can write it as normal. Then in PSVT, what happens? In PSVT, there are no P waves. You will only have narrow QRS complexes and they are regular. The RR interval is constant, right? It is not changing much. So make sure that it looks regular to the examiner. Don't write it looking like irregular and don't go by my sketch. Make sure that you write it looks regular, right? And label it as regular RR interval. So you can say there is absent P, right? And then you can also label that the RR interval is regular. Regular or constant RR interval, and that makes this case as PSVT. So when you try to represent visually, examiner understand that you know the stuff and they give you more marks. You may know it, but ultimately it is about how well you put it on paper, right? So try to make a visual representation for anything that you know. Even if you don't write all this, this is more than enough for the examiner to assess that you know the ECG findings of PSVT. Okay. Now, once we have recognized it on the ECG, how do we manage? Management of PSVT is particularly important. You need to write a beautiful flowchart. In atrial fibrillation, if you just mention like amiodarone, cardioversion, just list the drugs, you'll still get decent marks, but not in PSVT. Why? I'll tell you. So if it is a case of PSVT, right, what is going to be our first step? Any arrhythmia, what is the first step? Look at the blood pressure, right? Because hemodynamically stable means no shock, unstable shock. So we will see the BP first. If BP is, let us say BP is less than 90/60. See, basically why the interval difference? In the PSVT, there is a single focus which is generating an abnormal rhythm. In atrial fibrillation, there are generally multiple foci.
So what happens is all the atrial activity, like whatever wave of depolarization that is generated in the atria is not transferred to ventricle. But in PSVT, there is a fixed conduction ratio, and there's only one single ectopic focus. So you will have an expected interval of electrical impulse arriving at the ventricle, and the ventricular contraction will happen at an expected intervals. But in case of atrial fibrillation, there are generally multiple foci, and atria is haphazardly contracting. So some impulses are passed on to ventricle, some not, and that results in irregular ventricular activity.
Okay. So BP if in PSVT is, let us say, less than 90/60. Anytime BP is less than 90/60, what is our treatment? Shock. So what treatment we will give here? Cardioversion. Again, I'm reiterating only two conditions we give defibrillation. VT without pulse and ventricular fibrillation. Okay. If BP is more than 90/60, ideally we treat it with drugs. But in PSVT, we have more simpler steps to take. When those steps don't work, then we go for the PSVT. So then we go for the pharmacotherapy. So step number one BP is less than more than 90/60 normal, is to go for vagal maneuvers. Vagal maneuvers. Now we all know that vagus nerve belongs to parasympathetic nervous system. And what is the impact of parasympathetic nervous system on the heart? Decrease the heart rate. Sympathetic adrenaline increases the heart rate. Acetylcholine parasympathetic decreases the heart rate. So if you do some physical maneuvers and stimulate the vagus nerve, it can decrease the heart rate, and that may terminate this PSVT, because PSVT as such is usually intermittent, stays for a short period of time. And if I activate vagus, I can make it terminate much earlier. So we'll try to activate the vagus nerve. So what maneuvers can activate the vagus nerve? It can be carotid sinus massage or carotid massage. You know, there are carotid sinus which is connected with the vagus nerve. By activating it, we can activate the vagus nerve. Second thing that we can do is Valsalva maneuver. In ENTO studied about Valsalva maneuver. We can ask the patient to do that. When we try to exhale with a closed glottis, we build strong intrathoracic pressure. And because vagus nerve has this intrathoracic force, that increased intrathoracic pressure compresses the vagus nerve and it makes it fire incessantly or activates it, and that can again bring down the heart rate. And there are also modifications of this Valsalva maneuver, like blowing in a closed tube or the syringe or device. Those can be applied. If that converts the rhythm to sinus, good. Right. If that fails, then we can go for the step 2. If these vagal maneuvers fail, we can go for the step 2, which is pharmacotherapy. And in the pharmacotherapy, the drug of choice is adenosine. Adenosine is the drug of choice for treatment of PSVT. And we have to remember that adenosine is a very short acting, very rapid onset, short acting drug. And for that reason, it has to be given IV, preferably through central line. Preferably through central line. Because its half-life is just few seconds. So by the time you give it through peripheral line and it reaches the heart, its action is gone, because half-life is just few seconds. So when we give it through central line, we're reducing the distance between the heart and the point of entry of the drug. So more drug will reach the heart through central line. Here examiners do expect you to know the dose, right? So generally we give first dose as 6 milligram. We can totally give 3 doses. So the second and third dose can be higher. Second and third dose can be 12 milligrams. So cumulatively you can give 6 plus 12 plus 12, that is 30 milligrams. After 30 milligrams, if the rhythm is not converted to sinus, then we go for the step 3. Step 3 is what? Now I don't have any choice but go for cardioversion, shock. If the drugs do not work, I have to go for shock. Now the question is, what if there are contraindications for adenosine, right? So we should know a little bit about adenosine. Adenosine, right? So the side effect wise, it is known to cause bronchoconstriction. And because it causes bronchoconstriction, it is contraindicated in patients with asthma and COPD, right? So it is contraindicated in patients with asthma and COPD. Contraindicated in asthma and COPD. So in such patients, right? So what are the alternatives to adenosine? Alternatives to adenosine. So what can I use? I can use calcium channel blockers, non-dihydropyridine calcium channel blockers like verapamil or diltiazem. And can I use amiodarone? Yes, we can also use amiodarone. So today for most arrhythmias with our closed eyes, we tend to use amiodarone. So any arrhythmia question, you can roughly write amiodarone. Most likely you will be right. Okay, so this is our approach to the paroxysmal supraventricular tachycardia. To summarize again, what you should write in the description or definition, it is a arrhythmia which originates above the ventricle. It's there in the name, right? Supraventricular. And we are using the term paroxysmal because it is not a persistent arrhythmia. Comes and goes, and onset is rapid, termination is rapid. Clinical features for all arrhythmias, you are writing the same thing. Causes also for atrial fibrillation, like the causes that we mentioned here, again you can replicate for all arrhythmias. It's fairly acceptable, right? If you write same things for the atrial fibrillation, okay. You write the same thing for the atrial flutter, okay. You write the same thing for the ventricular tachycardia also, okay. Then in the diagnosis, yes, the objective information that we would be looking for in the question is on ECG. In atrial fibrillation, I want you to mention that the clear identifiable P waves are absent, but instead we will have fibrillatory or F waves, and the RR interval is varying and QRS complex is narrow. So in PSBT, I want you to clearly mention that it is a narrow complex tachyarrhythmia with clearly identifiable P waves being absent and the RR interval is constant. Management wise, yes, you have to put this algorithm and you have to also make 1 or 2 points note on the adenosine, its side effects and alternatives to the adenosine. And wherever you write adenosine, you should clearly mention that it is the drug of choice and highlight it for the examiners. So that's it about the today's questions. So every system we are dealing with around 10 to 12 questions, which are most frequently asked in the university exams. So in the next class, we will start with the another system. So till that time, you can definitely go through the notes as well as in the app, the Farre section. There's also a printed notes available and more questions are also available on like smaller questions which you can go through. So keep reading those Farre notes from the class as well as the app notes. Hopefully we will be able to crack 70% of the questions that will be asked in your university paper. The remaining 30%, whatever you know a little bit, build some story around that and examiners will give you at least some marks out of that. Of course, not zero if you have some 1 or 2 concrete points to address there. That will reasonably take us to the first class zone, if not close to distinction, right? So with that, I'm signing off today. The next session on the Farre is, I think, going to be from the pediatrics faculty. I'll be back after the weekend and we'll start with the medicine, right? And don't worry, all the systems, including GIT, hematology, neurology, endocrinology, everything will be addressed in the similar fashion. Okay. So see you guys. Good time.